Warm good evening to one and all. And it's just a big privilege and pride to introduce Dr. Rajagopal. First, I submit my humble regards to you, Dr. Rajagopal, for accepting me also as part of his family of Palliative India. Dr. M.R. Rajagopal is world renowned. Okay. And it's really a privilege to have him introduce and take you through this program, because you're going to get it from the horse's mouth. Nobody else can teach you what is palliative care. Okay. And he is the founder and chairman of Palliative India, Trivandrum. His initiatives have not been easy. He's brought in big initiatives to India, which needs it, and mainly to make morphine available through the regulations, through the narcotic regulations, for which he has worked so hard. And now it is available because morphine is gold standard pain relief medication. So that is being made possible for the public of India. And he's, as I said, he's world renowned. The international organization Human Rights Watch honored him with the Alison Desforges Award at Los Angeles in 2014. And also a documentary was released in 2017 called The Hippocratic by Moonshine Agency Australia, which made the whole world know of what he has done. And he was named one of the 30 most influential leaders in hospice and palliative medicine by the American Academy of Hospice and Palliative Medicine. And in 2018, Dr. Rajagopal was honored with Padma Shri, the third most highest award given in India. And recently, he has released a book, Walk with the Weary, which I think all of you would be a worthwhile read. So with that, I would humbly request Dr. Rajagopal to take us through the session. Thank you.
Radha, thank you. Good to see you after how long? A month and a half. And funny in a way from here to see that you are wearing warm clothes.
It's 10 degrees.
Here we are all sweltering in the heat and losing sweat by the buckets. So, hello everybody. Hi. Give me a smile. Give me a smile.
Hello, sir.
Smile, please.
Hi, sir.
Hi, hello.
Hello, sir.
This morning, I spent about 45 minutes with Dr. Rashmi. I don't know if Rashmi is here already in the group. She was planning to join us.
Yes, sir.
You are here. Okay.
Yes,
Hi,
sir.
Rashmi. So I emotionally blackmailed into her into joining today. During our conversation, purely coincidentally, Rashmi told me about her experience with a person on dialysis. She was asked, this man asked her, something like, what's the point of me being alive? Of course, it was in our mother tongue. Rashmi, what exactly was the question? Will you repeat that, please?
Sir, shall I repeat it in Malayalam or
Yes.
Malayalam?
Yes.
He was asking me, Ola, ഞാൻ എന്തിനാ ഇങ്ങനെ ജീവിച്ചിരിക്കുന്നത്? ഞാൻ ജീവിച്ചിരുന്ന കാലത്ത് ഒരുപാട് പേർക്ക് ഉപകാരം ഉണ്ടായിരുന്നു. ഇപ്പൊ ഞാൻ ഉപകാരം ഇല്ലാതെ ഇങ്ങനെ ജീവിച്ചിരിക്കുകയല്ലേ? നമുക്ക് ഇങ്ങനെ ജീവിക്കാൻ താല്പര്യമില്ല.
Rashmi, thank you. So the question to Rashmi, for those who do not speak Malayalam, daughter, why am I alive? When I was really alive, I could do something for others. Now that I am useless to everybody, I no longer have any interest in life. The man is possibly undergoing dialysis 2 or 3 times a week and his life would be revolved around those dialysis. What he is showing is total loss of hope. How can life be meaningful without hope? Sadly, possibly about certainly more than 7 million Indians. Sri, are there people from any other countries apart from the faculty, Radha? Are there any?
No, sir. This is a purely Indian.
Pan-Indian. Okay. Okay. So in India, certainly at least 7 million, possibly most probably closer to a crore of people are living with a question inside them. The question that that gentleman asked Rashmi, what's the point? The person is suffering, very obviously, isn't it? We are going to talk about that 1 crore of Indians who every year suffer from serious health-related suffering. And it is the privilege for every one of the around 50 of you participating in this virtually to be able to do something about it. Usually, you all must have faced this question at some point of time. Maybe even within the family, a grandparent asking this question. Oh, am I alive? Or a relative, or many of your patients. If you are not that kind of doctor who is very tough and like this, and wearing a white coat, stethoscope, and all stiff, you know how degrees add to the muscle tone? With every degree you accumulate, you become a little more stiff. Your voice assumes a certain authority. If you are that kind of frightening doctor, you may not face the question. Only your assistant or the nurse will hear the question. But if you look human enough, you would have faced this question. We are going to talk about relieving the suffering of that 1 crore of Indians. We are going to talk about doing our best to make them feel that my life is not in vain. My life is worthwhile. And when we are able to answer that question, you will find that it is strengthening. After all our medical education and medical practice, finally, you will acquire some strength not to run away from the question. Very often we run away from those questions. So friends, welcome. Welcome to the journey that we are going to travel together. The journey of very worthwhile and strengthening journey of palliative care. I'll share my screen at this point of time and share a PowerPoint with you. Please give me a second. I hope my screen is visible.
Sir.
I don't know whether you have ever wondered, how do you define your duty of care to the patient? If somebody stops you someday and, hey, wait a minute, doctor, what's your duty of care to the patient? You might have been tempted to think it is to diagnose and cure diseases. In many countries, including where Radha is, United Kingdom, the duty of care of the healthcare providers defined by law, not in our country, but a government's official body, a statutory body, Indian Council of Medical Research, and its bioethics unit has defined the duty of care the doctor like this. It is to mitigate suffering. The next 3 lines that you see are from a 14th century aphorism: to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. Dear doctors, Dr. Bhargav, Chavanga, Harini, everybody, please remember, our fundamental duty of care as healthcare providers is to mitigate suffering. And please note the last 2 lines. There exists no exception to this rule. I bet during your medical education or dental education, whatever you have had, this was not what was taught to you. You were taught about diagnosis and curative treatment. We are going to talk about mitigation of suffering. Mitigation of suffering would include prevention and management of suffering. By the way, this whole document is available for free download on the ICMR website. Now, this is not the World Health Organization definition of palliative care. But before I show you the World Health Organization definition of palliative care, I wanted you to see this and to grapple this into your heart. Palliative care is mitigation of serious health-related suffering. Palliative care is prevention and treatment of serious health-related suffering, which is taken as part of healthcare in most high-income countries, but in low and middle-income countries, sorry about the acronym, LMICs are low and middle-income countries. And particularly India, it is seldom relieved. It is estimated that less than 2% of the population, even basic pain relief reaches less than 4% of our population in our country. 7 to 10 million of them are in India. We do not treat suffering, and that's a global error of omission. But there are other errors of omission errors of commission that we make. Not only are we not relieving suffering, would you believe it, doctors? We are worsening suffering. Catastrophic health expenditure destroys 55 million Indians every year. What are we doing? After all our medical education and post-graduation and post-graduation, we are all contributing to the destruction of 5.5 crores of our people. Is that healthcare? If health is defined as physical, social, and mental well-being, are we not destroying health? And please remember, this job that we are doing of relieving serious health-related suffering is not only for end-of-life care, it is not only for cancer or HIV, it's for any serious health-related suffering. That's a busy slide. I certainly do not expect you to remember all these percentages. Just wanted you to see the magnitude. Of the whole lot, only 28.7% are cancers. 22.2 is HIV. But remember this whole bunch, 26 point something are central nervous system diseases and a wide variety of everything else. Is it your job to relieve suffering for people with injury, poisoning, and external causes? Amarnath, Nandini, Haricharan, is it your duty? I hope you will be able to say, yes, it is our duty. We have the privilege of being doctors, and that privilege goes with the responsibility of relieving suffering. We will not discriminate in the name of a diagnosis. Some of you will be working in cancer hospitals which see only cancer. That's understandable. But in principle, let us accept that our duty is beyond a diagnosis. Remember? Is there anybody who has never seen a scar like this on a patient's neck? I have seen more than enough in my life. Oh my God. I hope I won't have to see another. People trying to kill themselves. And these are the numbers from the National Crime Records Bureau of India. 1/5 of all suicides in our country are for health-related suffering. And in most of the suffering that I described, catastrophic health expenditure, number of suicides from health-related suffering, India is among the worst 10 in the globe. Such a lot for us to do. Let us see it as an opportunity, friends. And a different era of commission. This morning I got a call from Delhi. A patient in one of the best-known corporate hospitals with advanced cancer is put upon a ventilator. The family is allowed in for, usually it is 5 minutes, but in this hospital they are allowed in for 10 minutes. They want the person with them. They wanted to ask the doctors to move them to a room. No. He is on a ventilator. He cannot be moved out. This horrendous situation is fairly typically Indian. Not many countries do this. Which is why the British oncologist of Bengali origin, Dr. Sankha Mitra, who does charity work in northeast of India, says in India the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators. No one gets a pain-free and dignified death. Sorry, I painted a very grim, gloomy picture. As I said, these are problems, but they are also opportunities to every one of you and every one of us. Praveen, Premnath, opportunity. There is so much to be done. Your life can be worthwhile, and we together can take away a significant chunk of this suffering. While my friend's family is suffering in that ventilator in Medanta Hospital in Delhi, remember, National Cancer Grid, the conglomerate of cancer institutions in the country, have together prepared this guideline. Do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. This is what is recommended. You know what is the practice. And this is particularly Indian, I said. Globally, this is from European Union countries, where they can afford anything, they find that 90% of patients in a ventilator on life support systems are taken off the ventilator and instead given palliative care and allowed a natural death. 90%. The 10% is understandable. You cannot always predict death. See? And that kind compares with what is happening in India. only 30% of people are taken off the ventilator or life support systems, and they do not get palliative care also. They are left to die in misery. 70% of people are continued on the life support system and die horrible deaths, lonely deaths, separated from the family. I'm sorry, I must be hurting some people in here. If there are 50 people, I am sure there will be 1 or 2 people who are in the audience, have this experience of the same thing in your own families. I will not ask who they are because sometimes the answers to the questions can be very painful. But if anybody wants to has such an experience and is willing to share something, please write it on the chat box. Sri, if somebody does give a comment on the chat about this, please remind me.
Yes.
See the opportunity? We have to make sure that, like in Western European countries, if treatment is futile, not only they should not be subjected to meaningless life support measures, but they should be given palliative care. This is the task before us. Is there anyone ready yet to share an experience?
No, sir. Nothing has come on the chat box so far.
Okay, thank you, Radha. No, we mentioned that palliative care is mitigation of serious health-related suffering. Remember that the suffering can be in all these domains. Pain, vomiting, breathlessness, punctuating wounds. So many things that can be physical, but also the isolation. See the body language of the woman. She is alone in the world. This doesn't mean that people need to be physically alone. People can be lonely in a crowd. A person by name Jacqueline Johnson said, cancer can be isolating, and the isolation can be far more hurtful than the pain. Suddenly, you, the person with cancer, are on one side of the wall, and everyone else is on the other side, the normal side. That isolation happens because people feel not understood. Nobody else will understand my suffering. That is the reason why, part of the reason why that patient on dialysis might have told Rashmi, I do not want to live anymore. No purpose to it. So it can be social, relationship issues, financial issues. It can be emotional, depression, anxiety, guilt. It can be spiritual. I think the question that was asked to Rashmi is essentially a spiritual issue. When we say spiritual, you will have more description about it as the course moves forward. But remember that spirituality is not necessarily related to God or religion. It is more connected with meaning of life and connections. When the person says, there's no point, why am I alive? That is expressing deep spiritual anguish. When a person says, I am alone, nobody understands me, that means that person is getting disconnected from the world around them. And if you have heard some of these things from your own grandfather or grandmother, maybe after the course, you will do a fantastic job sitting down with that grandparent and eliciting feelings and giving them the appropriate care. I haven't talking about serious health-related suffering as the focus of palliative care, but I must also tell you about the WHO official definition. Unfortunately, the official definition is 21 years old, very old. WHO wanted to revive it. Asked one international agency to prepare a new one. Unfortunately, the prepared one did not meet with approval of WHO and other organizations. So officially, this still stands good enough. It's about quality of life. Not only the patient, but also the family. I said if there are 50 of these people, there have to be one or two who have the experience of a loved one going through serious health-related suffering. And they will understand that sometimes the family's suffering may not be less than the patient's and may sometimes be even more. I can see at least 2 people nodding on the screen. So we will not consider the families bystanders. Instead, we will see them as human beings needing our care. So it's about quality of life of patients and families, not only length of life, but quality of life. Associated with life-threatening illness. I want to spend a few seconds on that word. Life-threatening. Hey friends, what is life? He was Rashmi's patient. He was still alive. But he felt life was not worth living. So here we are not only talking about length of life, but about quality of life. And if quality of life is threatened, that's also needing our care by prevention and relief of suffering. That phrase is already there in the WHO definition. And a lot of words there, some of them are needed. If there is one major problem with the definition, it is this, it is too long. But by assessment and treatment of pain and other problems that are physical, psychological, social, and spiritual. Shall I have not finished, but shall I stop there and take a question or two about what I have said so far? Honestly, I myself am getting bored hearing my own voice. Ramadevi is smiling broadly. Yes, I am also bored, is what the smile says.
No, sir. It's nice to hear your voice after long time. I'm enjoying it actually, sir.
Thank you, Rama. Hey, anybody? Any comment or question about what I've discussed so far? Sri Priya, you must take this time to give me an allowance to eat into the discussion time. Okay.
Yes, sir.
Sir.
Yes.
Hello. Can you hear, sir?
How do you pronounce your name?
Yes. Savungbum Gyan Singh.
What's your short name that friends call you with?
Gyan will do, sir.
Gyan. Okay. Gyan, where are you from?
Gyan will be there.
Gyan, where are you from?
Imphal.
Oh, hi again.
Sir, I have one question. As you were saying that in the developed countries, the percentage of patients in the last stage or of life, they are who are in ICU care is only around 10% in stage life. But in India is 90% are removed, but in India only 30% are removed. 70% are in ICU. Do you think this is because of the policy program or is it because of the individual practice? What could be the reason for such a big gap in that percentage?
The reasons are complex again.
Yes.
In the sense, it is not one reason. It's a multitude of issues And if I can quickly find a PPT, I'll show it to you right now. Wait a minute. In the meantime, anybody, any other question while I look for this PPT?
Sir, may I ask another question then in between?
Yes, yeah. Thank you for saving me from boredom.
So in the definition, in the WHO definition,
yes,
there I noticed one particular line, early detection, so to say.
Early?
If we can come back to that slide also, sir.
Yes,
I saw something like it's early detection and diagnosis, so to say. This particular word early, in a palliative care scenario, we are talking about palliative care. Is it absolutely necessary? I mean, if it is not early, then does it mean that we can't give a palliative care? The value get lost?
Is it? Important question. Thank you. If it is late, it is still palliative care, but palliative care given late. Listen, if I am your patient, and I am suffering, I would like my suffering to be treated as early as possible. That's all that it means. As early as possible, we want that treated. So, of course, thank you for the question. Even if you give it late, it is still palliative care, but you aim to give it as early as possible.
As early as possible. Okay.
So I have the slide again. I'll show it to you now. What am I doing wrong? If this time also I fail to show the right slide, I am going to give up. Oh.
Sir, if you are not able to share, it will be okay if you can give us some idea. Basic,
thank you. Very sensible. He is saying, stop wasting time. Let us have some sense. Absolutely. The slide was supposed to show a series of barriers to proper end-of-life care. And there, the first barrier is doctors' perception of duty of care. I strongly believe that most of the time it happens because doctors believe they have a duty to prolong life at all costs. Let me ask the 50 doctors here, do you have a duty to prolong the heartbeat at all costs? If a person with advanced cancer is dying, do you have the duty to try CPR? And Ramadevi, thank you. You do not. There's no document, no ethical principle that says so. But yet, in our country, doctors, especially in the last 25 years, so it's only a quarter of a century old, new problem. doctors genuinely believe that they have a duty to prolong life at all costs. The second one is, over these 25 years, public also has taken it for granted very often that even everybody who is dying should be admitted to the ICU. And all the family will come and ask, hey, are you not taking him to such and such a hospital? You are keeping him here, not in an ICU. Thirdly, there are sometimes societal reasons, apart from the family's attitude, larger society itself considering that as mandatory, and especially because withdrawal of life support, what I described in the European countries, is sometimes mistakenly seen as killing, euthanasia. There are religious objections also. And finally, India does not have a law covering this. There is a Supreme Court order brought in earlier this year, which says, yes, you can withdraw the ventilator, and then they put in a complicated process, which is not practical. So it is doctor's perception, family's attitude, societal attitude, and legal barriers. The legal barriers can be overcome if we apply our minds to it, but very often it is not done. I'm sure you will have this discussed in greater detail during the session on end-of-life care.
Thank you, sir.
Yeah, and thank you for the question. Again, what was your second question? Did I answer that?
So you have given some idea. In the WHO definition, they have specifically mentioned early.
Okay. We talked about it.
Was...
Thank you.
Okay.
So coming back to the WHO definition, early identification and impeccable assessment, etc., all unnecessary words. But there is a great importance to what Gyan asked. Let me come to the next footnote to that definition. This WHO definition carries 9 footnotes, and one of them, Gyan and everybody, says that palliative care is applicable early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage distressing clinical complications. It is okay if we can give palliative care, and we must give palliative care when the suffering starts. At one time, prior to that, we used to say, okay, initially it's curative trial, you stop it and then give palliative care. No longer. You continue disease-modifying treatment and provide palliative care along with that. And eventually, when the patient dies, palliative care does not stop. What do we mean? Palliative care is for quality of life of patient and families. Support for people who are bereaved is part of it. Bereavement support. But in our country, even basic pain relief reaches less than 4% of the needy. What you are seeing is the WHO analgesic ladder, for which 2/3 of cancer patients and a large number of other patients with other illnesses will need strong opioids like morphine, which is available to less than 4% of the needy in our country. It is not my intention to go to every symptom at this stage. Those you will talk about later. But including pain relief, that pain and other physical symptoms, psychological, social, and spiritual suffering, this is not only to be done by you. Dr. Amarnath, Dr. Praveen Raj, Dr. Nandini, you will become palliative care physicians. You don't have to be full-time palliative care physicians to practice palliative care. You can integrate palliative care into all health systems. That is what we are asked to do at all levels, primary, secondary, and tertiary levels, across the continuum of care, from the beginning of the suffering to the end. And I'll to skip that. into health systems at all levels across the continuum of care. That means your palliative care, if you are running a palliative care unit, that will take care only if a small amount of the extent of the problem. Dr. Amarnath, what do you do? Please unmute and speak.
Good evening.
Hey. What do you do? Some problem there. Dr. Laishram Rajesh Singh, what do you do? If you click the unmute thing, click only once and give it a fraction of a second. Praveen Raj, Bhanu, what do you do? How come I am getting such a silence?
Sripriya, is there any issue, dear? Why are they? Is there anything that you?
I can see Dr. Banu, but I think her audio device is not enabled. That
Okay,
is
okay.
why
Doesn't matter. Doesn't
No.
matter. Okay, whether you are a sorry.
If anyone wants to speak,
Yeah.
also they can come up and say what they are doing, isn't it? Just to know what variety and what is your.
Sripriya, maybe next time, before we start, we can have an exercise. Everybody making sure that they are able to unmute and take part in the discussion.
sure,
Otherwise,
sir.
it will be a monologue.
Well noted, sir. We will ensure.
Thank you. So, whether you are a pediatrician or a pulmonologist or a maxillofacial surgeon or a periodontist, whatever you are, if you follow the principles of palliative care in your practice, that is integration. If you start smiling at the patient, you have started giving palliative care. If a patient is looking very scared, when you lay a hand on the hand and say, you seem to be a bit scared, you want to tell me what it is? And if the patient is silent, just say, I'm going to take care of you. That will be reassuring. That's palliative care. And if you give the safe and effective analgesia after any procedure, that is also palliative care. If somebody is extremely anxious, then being able to deal with that is palliative care. When that man on dialysis told Rashmi, what's the purpose? I don't want to live like this. If you have some way of infusing hope, or if you see your way of to see whether his demand is just and whether he has 1 hour or 1 year to live, infusing life into that time is palliative care. So this is for anybody to include in your practice. And on the foundation of all is participation of the community that will have to be supportive to the patient, to the family, and to you. And as the course moves forward, you will hear more about it. This integration can be at the national policy level. For example, the undergraduate medical education now since 2019 includes palliative care. If a hospital or you yourself in your clinic includes it, that's micro. And this naturally will meet with some resistance. Any new change that you want to bring in your hospital, there will be some resistance because change brings in fear. Oh, I will never be able to do it, kind of feeling. That's also common, normal. And as we move forward with the course, you will have a discussion about how to organize your palliative care service and how to get it started. My time is up. I think I'll stop there. And take any questions. And in the meantime, Amulya says Many times, even if the patient wants to end their own suffering, the family isn't ready. So Amulya, thank you for the very important comments. Yes, remember what I said? Doctor's perception of duty of care, family's feelings, etc. Have you noticed your love for your family members can be two kinds? If it's a selfish kind of life you love, you will say, I can't live without my mom. I want her to be alive. If it's a little more selfless, you will say, my mom is suffering so much. If it is time for her to go, let her go in peace. So it requires our help also to the family to come to that stage. But that's only in the context of incurable illness. We have at least 10 good minutes for questions and answers.
So before we take up further questions, I just wanted to bring to your kind attention that we are privileged to have Dr. Rajagopal Kaur, who happens to be the Director of Department of Health and Family Welfare, Punjab. And she has joined us along with her team of 15 doctors of DHFW and who are part of this training now, sir.
15 doctors from?
Department of Health and Family Welfare, Punjab.
Oh my God. This is huge. Sorry, what did you say was the name?
The director's name is Dr. Rajagopal Kaur. So
I'm looking for them on the screen. I haven't located them yet. But Dr. Adarsh, this is such a privilege. Punjab particularly, unfortunately, this progressive state, which is more progressive than most of the country, in many ways, unfortunately has not kept pace in the matter of palliative care. Part of the reason is it's a border state, the problem of smuggling of opioids across the country has made the state very sensitive. The high incidence of addiction in the state is also very sensitive. So your presence is very vital. Thank you very much, Dr. Adarsh. We will particularly talk about how to institute palliative care access safely. Thank you for being here.
So we launched this scheme recently, and we hope that we'll cover up the deficiency.
Madam,
about the addiction, etc. The government is taking good care and very sincere and serious about this issue.
Madam, which state are you in? Sorry, which city are you in?
Punjab Health Services. You wanted to
which
have
city?
a look, and I have switched on my video, sir.
Yeah, please. What's the name of the city? Are you?
I am in Chandigarh. My office is in Chandigarh based, but I represent state head Punjab.
Okay. Very good. Very good.
Yes, sir. Good afternoon. Good afternoon, sir. Ma'am is the state head. She is the Director of Health Services. And she's looking after whole state of Punjab. Sir, I'm Dr. Jaskiran. I had met you once in Chennai, sir, when there was a palliative care workshop in 2020. And sir, it's been a long time. And definitely, as ma'am has said, that we are now committed, and we will definitely, we are paving up. And that is what we took the chance through ECO. And ma'am consented that she will be also present throughout the sessions, which is also very wonderful for us that she has
Phenomenal. Phenomenal is the only word. Thank you, Dr. Adarsh, and thank you, friends. So, Sri, you will let the facilitation team know about this, and certainly they should also join our organizing palliative care section.
Sure, sir. They are part of this training as formal participants. So we would like that they would attend all the sessions, almost all sessions as far as possible. And in due time, sir, of course, we will get them connected to the state facilitation team as well, sir.
Very good. So Thank you. Any questions or comments before we go on to the next part of case presentation?
Sir, I have one question.
Gyan again?
Yes, sir. Gyan,
yes,
sir.
Gyan. Thank you.
Sir, when we are talking about palliative care, we are saying it's not confined to the patient, it includes the family. So, means basically we are talking about more than one person or one unit. So, if there is in a scenario where there is a very contradictory opinion between the patient and the relatives, or let's say, and the family, how do we go about managing such a scenario?
Very, very common, Gyan. It happens all the time. Yes, so I earlier mentioned about the selfless love and the selfish love. There'll be different kinds of people in the family. And two people will say, whatever he says, don't care. Take my dad to the ICU. I want him to be alive as long as possible. And the other person will say, can't you see he's suffering? If it is time for him, let him go. And this conflict will happen. And the man or woman herself may not be in a position to say anything at this point of time. So, why are we talking about others? You are talking about me tomorrow. So what I have done is I have prepared my advance directive. I have talked to my family. I have got consensus within the family to be kind to me. But if it is not there, Gyan, what we actually do is to have the family sit around together, sometimes listen to the people separately, and eventually have the brothers and sisters around the same table. Acknowledge their love. The person who doesn't agree with your advice is not necessarily an enemy. That's a person who deeply loves his dad or mom. Acknowledge their love, respect their love, and still come to the question of quality of care. You will have sessions on communication, including communication of bad news. And this issue of collusion within the family will come up there. It will be discussed in detail. Sushil, what was that question? Yata, can you see a question? Sushil Chuk.
I'm reading it for you, sir.
Yeah.
I'm just reading it.
Thank
How
you,
is
Rata.
palliative care different in terminal disease and conditions causing long-term disability? He is Dr. Sushil from Physical Medicine and Rehab physician he is. So I'll repeat, how is palliative care different in terminal disease and conditions causing long-term disability?
So, Dr. Sushil, you are asking what is different. Let me tell you what is common. What is common is the emphasis on quality of life. As I said, if I have only 1 hour to live or 1 year to live, Dr. Sushil, your objective, I hope, will be to fill life into that hour or year. Life, love, hope. You will try to see what's important for me at that point of time. So, Dr. Sushil, you are a physiatrist, and in our unit, as Radha knows, we look after about 120 people with paraplegia, spinal injury, and maybe a larger number of people who have a post-stroke with serious disabilities. Is that a life-threatening condition? It is, if life is not measured only in length. A person whose life is confined to 4 walls is having a life-threatening illness. We look after them. The emphasis on quality of life. The emphasis for those paraplegics, people living with paraplegia, is to get them as independent as possible. That means teaching them to move by themselves from the bed to the wheelchair. By assisting the family to make the rooms accessible, to make the home accessible, to get the person educated if he or she is interested, to find them a vocation also, but also to treat their central pain, their pressure sores, and all physical problems, to prevent the urinary infections. All that is part of palliative care. But if it's somebody who is dying, then also it is still attempt at improving quality of life of the person. Is there things that what is most important for him or her at that point of time? That's what we concentrate on. But in end-of-life care, compared to the other situation, the focus shifts away from organs or mobility. We stop doing those investigations that are not going to be useful anymore. Instead, it's more about having the family together, giving love, receiving love. You will have a separate session on end-of-life care anyway, and we'll also have sessions dealing with the other chronic illnesses, long-term care. But thank you. Yeah, officially my time is up unless there are any burning questions.
Yes, like as Dr. Rajagopal sir has mentioned, you will have everything in detail. So nothing to worry. All this in communication, you will have 2 sessions. So the whole structure is so well made. At the end of this program, you will know to some extent A to Z about palliative care, and you will be able to do and practice very efficiently and have successfully. See, looking after patient, and at the same time, you should be also happy that I'm able to deliver something. Secure care, both has to come from us. So everything will be covered and will be dealt with it. So nothing, it's a structured program which has everything. Yes, sir. So,
and yes, of course, adding to what Dr. Radha said, we are always open to feedbacks. So in case you feel that anything extra needs to be added, anything needs to be more focused upon, please do feel free to get in touch with us and convey that so that we can keep improving ourselves.
Definitely, Sripriya. That's also equally important. Always these feedbacks are for us to improve so that the whole structure and program improves and always getting more better day by day. So, Sripriya, with the case presentation.
Sure, ma'am. Today we are going to present a sample case from our end, Palliative India's end, so that the participants get a better picture how to bring in a real patient story and how to present it and how to go forward with the discussions. Anu, may we have the screen sharing, please? Yes. Dr. Grishma, so over to you.
Thank you, Sripriya. Good evening, sir. Good evening, madam. Good evening, all. I'm Dr. Grishma, working as palliative care physician in Palliative India. Today's patient detail. 39-year-old male whose diagnosis is traumatic artery paralysis, stage 4 pressure sore on sacral region and left gluteal region. Presenting complaints were constipation for 2 days, bedsore over sacral region and gluteal region, moderate pain over the hip region, and urinary leakage. History of illness. He had a history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic artery paralysis in August 2015. He was admitted and got treatment from one of the government hospitals and discharged after 1 month. After 6 months, he developed a bedsore over the sacral region and gluteal region, both were stage 4, and history of pain over the hip and wound site for more than 2 weeks. And pain over the hip region was 5/10 score and intermittent burning type of pain on both sides. And at the wound site, 4/10 score with continuous throbbing type of pain. Due to this, sometimes they keep the wound open and disturb sleeping pattern and decreased oral intake. On examination, he was conscious and oriented. Temperature was normal. Pulse rate was 82 beats per minute. Respiratory rate was 20. And BP was normal. And systemic examination, all the systems were within normal limits. Pressure source. Local examination, there was warmth and tenderness and exudates present, and tunneling was also present, and the wound was irregular in shape and was foul smelling. Routine investigations was done, and hemoglobin 10, total count was 34,000, and neutrophils 80, lymphocytes 18, and eosinophils 2. Platelet count was 1.6 lakhs. Serum creatinine was 0.9, and serum sodium 132, and potassium was 4. Psychosocial aspects: 39-year-old unmarried man living with his 65-year-old mother in a rented house, and he has one sibling, and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now his mother is a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wages, her pension, and some of his friends also help him. Have taken rupees 1.5 lakhs from private finance bank for the treatment purpose. And he was a Christian devotee and now unable to go to church, and this makes him very sad. And he communicates through cell phone and all, and he says to his mother, like, I don't think I can walk, so please don't spend money over my treatment. Main concerns were pressure sore, pain, and financial problems. Summary: a 39-year-old man with traumatic artery paralysis with bed sore present over sacral and gluteal region. Stage 4 with pain over the hip region. Discussion points: do we need to provide palliative care for this patient? What are the problems faced by this patient, and what can be done for this patient and his mother? Thank you.
Thank you very much, Dr. Grishma. And it's nice to see you, as you mentioned. This case is actually like for all of you to get an idea. See, as case presentation is also going to be part of this program. And all of you would have seen or had the opportunity to see most of these patients. So these type of patients. So this is just giving you an idea how to bring forward cases that you see in either in your practice or what you have seen before, something like that, for discussion appropriate to the day's current topic, whatever we will be having. So that is one thing. And again, for this part also, for case discussion, all of you can, either option you can say, that it could be either like you can unmute and ask, or you can type in the chat box. Both options are fine, so that we have an active interaction. And see, end of this program, you should not go back, oh, I have so many doubts. It would have been nice if these things were clarified. If that doubt comes to you when you're going to see the patient, that's not what is going to be helpful for you. So please feel free. Don't think, oh, this is a simple or silly question. How will I be? No, nothing like that. So feel free to ask, communicate, interact, and get the full benefit out of it. That's what is the first thing I would like to say. And now first, let us take one by one. Do we need to provide palliative care for this patient? What's the take from all of you? Yes, nice. At least all of you are actively responding. See, the whole session we have seen, and it's enlightened us to say what is that is needed. Okay. See, so many issues are there. We saw total. So umpteen issues, what we have seen described in the last 45 minutes are vividly shown here. So thank you. So we need to provide palliative care for this patient. Then what are the problems faced by this patient? From that point of view, like you can unmute and talk or type, either way is fine. You can unmute and speak also. That would be nice to hear. Yes, someone has typed financial issues, pain, financial, spiritual. little bit more explanation on then generally, physical, this first thing, uselessness. What did he say? Don't spend anything on me because I can't, I'm unable to do it. So that is purpose of life. That's what he is feeling. So what is that we can do? And help him. Helplessness also someone has mentioned. See, commonly what is said is when someone goes through this, that helplessness is a very deep down feeling which links on to many other things. Let me see, someone has typed depressive feelings, not being able to walk, worthlessness, helplessness, worthlessness, all those things affect his morale, that it affects his psychology. What would help him there? Take help from his church, counseling. Dr. Shushil, you can speak, you can unmute and speak also, Dr. Shushil. Yes, please.
Am I audible?
Yes, we can hear you. Go ahead. Nice.
Yeah. So I think we need to start with, speaking to them and understanding among all these things, what is most bothering to them, because there are multiple issues with them. And
yes, exactly. To find out what is the most bothering thing for him. That is what, see, we may see so many things. We may look at it as financial, all that, but only when you ask him, we will know. That's where that personal touch. Ask him, what is that's most bothering for you? And once he tells that, then from there you move forward. Say, there you can get help of psychologist, social worker, and it all depends on that answer from him. What is that's most bothering? Here comes multimodal management, team working. All that is so important. Just one-man show will not work in this. Okay, so multimodal management is what will give you the best result. So one is finding out what is bothering him, then moving forward from there. What is that it's needed? Psychological, social, financial. Picking that up and then linking. Don't think that some things cannot be. We have to try to see how to manage. So that is what we should try to work. Anything else you want to add on? I'm just seeing the rest in the chat also. Relieve pain, wound care, counseling. Give them an assurance, yes, that somebody is there for them. Yes, that is one thing which is very, very important. See, once you ask and say, what is that's bothering you? Okay, he says something, and then you find some link for that. If it is psychological, that feeling, then counseling. We have methods like, we will go through that also. We have cognitive behavioral therapy, teaching them how to overcome situations. And if it is financial, we can try and see what if there's some organization which can help him, linking that organization and him. See, maybe he may not have contact with everyone. So that's where multiple organizations and things come, community participation. If the church may have some aids and things, because he's linked to that church, that is something we can find out. The church may have the aid and he is there, just linking both. So something like that may work. Support group, spiritual upliftment. Anything else you would like to add on? Rehab, someone has said, yes, rehab is very, very important. That is what happens. Like, it'll be amazing if all of you get an opportunity to go see what happens in Palliative, because you have to see to believe. They have so many stages of care. So rehab part is done very, very well, which gives assurance to the patient. See, how many ever times you say, they have to also believe that they can do. So they have an excellent team who work together and make them do things. So then the patient will get the confidence, oh, I can do something. So that individual confidence will raise their, being able to do, will uplift their life. Organizing close relatives, neighbors, and help them to be out from the stigma of illness. Yes, that's what. So taking that extra time to talk to them. Yes. Anything else anybody wants to add on? Then what is the next thing? What all can be done for this patient and his mother? I think the second and third question, from the mother's point of view, what is that we can do? Anybody wants to add on to that? Yes, you were meant, like I think financial support is what will help the mother also. But beyond that, anybody wants to say anything else?
Helping her to understand what the son may be going through.
Yes. Helping, that is talking to the mother. And as Dr. Rajagopal mentioned, many times we have to spend some time, okay? Talking to the mother separately, talking to the son separately, and making sure both of them understand each other's situation. And again, it is the love only there. Hey, the son wants to help the mother, mother wants to help the son. But something else is bothering them. One more thing I wanted to say, just let me check how to lift his moral, emotional, financial support. And also, she is also burdened, will decrease the burden on mother. Okay, just one more thing, what I wanted to add on was, see, the mother will also get burnt out. So we can look at some respite care for the mother also. Because already she is doing, but her age also matters. He is young, she is old. So that also sometimes they want to do, but physically she may not be able to. So that can also be something to be kept in mind if there is a possibility of respite care for her. If someone will look after him for 1 or 2 days, give her some rest, and then she can come back and do more. So whatever she can. So that is something which came to my mind to mention. Help her to earn for themselves, and that she has to be strong enough to support her son's faith. Yes, that's all. Psychological support and help explaining things to the mother, because many times awareness, what exactly is the issue, what is happening. Caregiver, that's all. She is the sole caregiver there. So, and she is the breadwinner also. So both the elements are there. So that has to be taken into consideration when you see what is that which is needed. Okay, anything else is there in the chat box? Let me have a quick look there. Main thing is caregiver note. So that WHO definition also, what again and again they say now is patient and caregiver both have to be looked after. It is just not, it's dealt as a whole. So that also to be kept in mind, equal importance you give for both the patient, caregiver, family, all in total you start looking. Okay, anything else from the case point of view? Anything anybody wants to add on? We have dealt with the main points. So this is an example how we would like you to bring forward cases also. Thank you very much, Grishma, also for doing it for us.
Thank you. Thank you.
We can just go back. You can come out of this presentation and generally ask what is that, if anybody else wants to ask any specific questions or anything. And being the first day, any other queries or signing in. Anything anybody of you want to ask, please feel free. Both Sri Priya is also there. She could, hope all of you were okay with all that.
Ma'am, can you hear me?
Yes, go ahead. If somebody wants to say something.
Ma'am, just I had a query regarding the case presentation. Topics have been given like GI symptoms, respiratory symptoms. So we have to get the case like patients is presenting with those symptoms.
Sorry, dear, I can't catch your question. Can you please repeat?
Topics have been given like respiratory symptoms or gastrointestinal symptoms. So the main complaint should be those symptoms. Is the case should be like that?
Yeah. See, the main thing is that, see, for example, respiratory symptom in like a cancer or a non-cancer patient, anyone it could be. But the primary thing, because we have like so many sessions for you. Okay. Each session, see, for example, today was palliative care. Okay. This patient has other issues also, but does he need palliative care, or is he an ideal candidate for palliative care? So those were the queries. So like that, for example, I'm just going to pick up respiratory. Okay. Just to give an idea for all of you. See, respiratory symptom can be in a cancer patient or a chronic COPD, interstitial lung disease. Anyone can have, but interstitial lung disease also can be in an end stage where they are unable to breathe. They have had treatment, they did everything. So what I'm telling, say there, the respiratory symptom is the primary thing. Okay, that is what it is. So, okay, then I have seen some patient now, fine. No, I saw some patient sometime before had all these. So something like that also you can bring up. Okay, so it can be, see again, palliative care, it covers, Dr. Rajagopal, that one slide, you saw that demarcation, that showing a pictogram type of thing, isn't it? So it had so many things. Roughly, I'll tell you. See, 28% was malignancy. 26% was cardiovascular dementia. Dementia was a big chunk in that. Okay. And then you have another 30% of all the rest. So all these are part and parcel of palliative care. Here is where trouble comes. Not many of our own professionals are not willing to accept that. Okay. So you could have seen cases in any of that. So respiratory symptom in any of these patients you can bring up. Is that clear?
Yes, ma'am. Yes, thank you.
So like that, it could be anything. And then you add on everything. See that respiratory symptom, how much it is bothering him, what all. So when you see a patient or when you take a full history, it will have all these components. So start seeing a patient in total, not the symptom alone.
Yes.
So that is what will help you. And something related to that, even that all of you send, and then if any queries you have, get in touch with us and we can help you out.
Okay, thank you. Thank you.
Welcome.
Just
and
what Dr. Sorry, ma'am, please continue.
No, feedback forms and things will be sent on a daily basis. Please do fill in those ones so that it will help us to improve also. Yeah. That's what I wanted to add on, Sri Priya.
And adding to the case presentations, yes, we know that it has always been kind of difficult for everyone to apprehend at first. Just remember this, you might have come across at least one person, be it in your organization, in your practice, or in your family or friend circle, whom you now feel that you could have taken better care of if palliative care was inculcated. So that is what we require. There might be some element in that particular patient's story wherein you felt that, okay, I could have done better here if I could have known about palliative care earlier. And maybe you would still have some queries regarding, for example, as Dr. Swati said, in respiratory symptoms, maybe you would like to know what more can palliative care do along with this pulmonary branch of medicine while taking care of that particular patient. Because I am apologies, I am a non-medical person, but then I have heard many faculties say many times that palliative care is one branch of medical science which treats the patient, not only the disease. So maybe you can just try bringing in that concept, wherein you have just seen the illness till now, but now you wanted to see the patient as a whole and bring in the difference, that change. I hope that will help.
Radha, with your permission, and
No, sir.
wanted to add a couple of points. Grishma, thank you for picking that particular patient story. If you look at international literature, if you look at a textbook of palliative medicine, you may not find a chapter on paraplegia. Remember, all the literature, 96.5% of global literature on palliative care comes from Euro-American countries, which have only 15% of global population. There, paraplegia is different. You do not have the same kind of suffering there. If it's a person who gets a spinal injury, they have the spine fixed, go to the hospital in 2 weeks. The next month, you will see him or her in an electric wheelchair doing their own shopping in supermarkets. They have that system of rehabilitation, which is lacking in our country. So please remember, many conditions that we find serious health-related suffering in may not be seen in global literature. That's one point I wanted to make. There was another one. There was a chat question. Sri Lakshmi, you had a comment about that patient's mother. Help her to earn for themselves. I mean, like very, very sensible things. Everybody wants to take care of that son, give her mental strength. Great. Shift it to government hospital or rehabilitation center, government. Gurinder, that will be possible in a limited number of cities for a period of time. But then you go back home to the same old hell. What do you mean by mental support? Those are things that you will see, you will hear during the term. Making the mother understand what the son is going through. You first learn what the son is going through. Sit with him. Just say, this must be a tremendous pressure on you. Why did you say what you did? And then let his emotions come out. Sri Lakshmi, but about this thing, that she has to be strong enough to support her son's feelings. You must be strong. That statement is so common. That's what you want. Where do you get strength from? When an elderly mother has to look after that ailing son 24 hours, does not get enough sleep, does not have money, the debtors are coming and harassing her for returning the money that was lent, where would she get the strength from? And then we ask her to be strong. And her feeling will be, no one understands what I'm going through. Instead of that, you will have to sit with the person and listen. Remember, very often when we are confronted with difficult questions, we have to respond. We feel obligated to respond with a question, with an answer. Stop giving an answer. You don't have an answer yet. Look for the question behind the question. When the man says, Mom, don't spend money on me, you sit with the person. You were worried that the money, mom's money was being wasted. Why did you say that? And let him share the feelings. Similarly to the mother. This must be, instead of saying, be strong, you will say, this must be such a hard time for you. Tell me, how are you feeling? Let the emotions come out. After they have cried and talked to you for 10 minutes, they may wipe their eyes and say, Thank you for listening. I feel much better now. I was feeling so much alone that nobody understands me. So this business of communication is something that was not taught to you or I in our undergraduate training, something that we are learning. I learned it all for the first time when I learned palliative care or palliative care course. So these are things that we will have to learn.
So
okay,
take the freedom of 1 minute more with your permission, sir. Just wanted to share one story which I have heard from your own words. Just I will take 1 minute, sir. We had this nurse at Palliative, India, who once visited a home, and she found out that the patient was not following the medications given. The medicines were given for pain, but she was not taking it. Now, anyone would have scolded the patient, why you are not taking. But our team member, she wanted to know the root cause. She went into the kitchen and found that no food was being prepared in that house for 3 days. And the patient had not taken the medicine because we had strictly instructed her to take the medicine after food. So this is what basically palliative care is all about. We have to know the root cause. Sorry, sir, I have not heard this narration being said anywhere in our foundation course, but this is what touched me the most as a non-medical person. So I thought I would share it here with you. So that is what makes the difference. Instead of asking her why you are not taking repeatedly, that particular nurse went out to the root cause. Because of course the patient had to follow our instructions, the medical team's instructions that food has to be taken before they take the medicine. And there was no food. And that single incident had made Palliative India think about the food kit distribution, which we are doing still now. Sorry, sir, I had to share it. Sorry.
Thank you, Sri Priya. See, be considerate, be passionate. That is what we are trying to say. So that is something going beyond. So thank you for sharing this. And then it opens up all our feeling and thought. It's just not writing a prescription alone is the duty of the doctor. Be a human being within you also. Look at the other person as a human being. And that is what we need to do. And see, even if it is not there, like smile, you smile. Even if you don't have any quality, there's nothing wrong. We all can develop and be successful person also and a practitioner also. So thank you, and hopefully all of us with the able guidance of Dr. Rajagopal sir taking us through the introduction. So it with full flow, with compassion, empathy, everything is what we will all, with love and affection and caring, we will go forward with the whole program, and end of the day be successful practitioners also. A big thank you to you, sir, for taking us through.
Thank you, sir. Thank you for joining and making the session interactive. And we do hope that the sessions, as we go along, becomes more and more interactive or stays interactive. So with the promise that we'll be meeting again in the next session with another interesting topic and yet another eminent faculty. This is Sri Priya, along with Dr. M. Rajagopal and Dr. Ratha Venkatesan, signing off from the TIPS Eco Hub. Stay tuned with us. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you.